Good afternoon, everybody. Welcome to our report briefing. I'm just going to wait another couple seconds as folks trickle in. All right, well, good afternoon, everyone. Thank you so much for joining us. We are thrilled that you're all here for our report briefing on our newly released report, where we are looking at primary care access and equity in New York City. Quickly, I'm Mary Ford. I'm PCDC's Director of Evaluation and Analytics, and I will be joined later in this presentation by Kirsten Weisbeck, who is the lead analyst on the report that we're talking about. And we'll also be joined by Maura, who is PCDC's Policy and Advocacy Manager. So just a little bit of background about PCDC. We were started in New York City in 1993 by the Dinkins administration, and today we are a nationally recognized nonprofit with a mission to advance high-quality primary care and to achieve health equity. At PCDC, we wear many hats. But broadly speaking, we have three main functions. The first being capital investment, where we offer affordable capital to primary care providers and organizations to build, renovate, or expand their physical space. We also provide capacity building and technical assistance to improve clinical operations and help providers with their provision of high quality, culturally competent care. And then we also advocate to advance policy at local, state, and federal levels to increase access and investment in primary care. And then certainly last but not least, we also have an evaluation and analytics team who works really across all three of these functions, but we also work on publishing timely and actionable data and analyses on a range of topics related to primary care access. The project and report that we're talking about today is part of a project that we sort of affectionately call the PICSNAP project, or Primary Care Safety Net Access project. This was really initiated somewhat more formally in 2017 with some discretionary funding from the New York City Council. And the goal of this project has really been to produce meaningful and insightful data and analytics related to primary care access, health status, and socioeconomic factors at the city council level, both through a series of reports and an interactive online dashboard, which we will be sharing shortly with you through the chat feature, to be sure to check that out. As many of you may know, there aren't many data points available at the city council specific level, even though we do, I'm somewhat lucky in New York City to have access to a lot of published health and socio-demographic data. But our goal here is really to equip policymakers with actionable data and insights by council district. And today we are here to talk about a report that we just published in 2021, where we are looking at primary care access and different elements or qualities of equity in New York City at the council district level, of course, but all really through the lens of COVID-19. Today, we've really summarized some of the key findings and provided policy recommendations in the report that hopefully are very helpful and interesting for you to hear about on the call. We are happy to collaborate with and serve as a resource to any of you today who are looking at and thinking about similar issues that face New Yorkers. And throughout the presentation, we really welcome questions and comments through the Q&A feature on Zoom. And we will try our best, sort of time permitting, to get to those at the end of the call today. So without further ado, I am going to hand it over to Kirsten Weisbeck to talk through some of the key findings from the report.
Great. Thank you very much, Mary, and thank you all for joining us today. I am going to, as Mary said, walk through some of the key findings of our report. But first, I want to just take a brief minute to review some of the epidemiology of COVID-19 in New York City. As the first epicenter of COVID-19 in the US, the pandemic has had, of course, an unprecedented impact on the New York City and the health of New Yorkers. In this report, we looked at both case and death or mortality rates of COVID-19 as of February 2021. So as of February of this year, of the 5 districts with the highest case rates, included 3 in Staten Island, districts 49, 50, and 51, which include many neighborhoods, including Fort Richmond, Snug Harbor, New Dorp, Great Kills, and Totenville. And then District 48 in Brooklyn, which contains Brighton Beach, Manhattan Beach, Sheepshead Bay, and the Midwood neighborhoods, as well as District 21 in Queens, which is home to Elmhurst and Jackson Heights, were also among the 5 districts with the highest cumulative case rates. And then as far as both of those districts, 2 districts I just mentioned, 21 in Queens and 40 in Brooklyn, were also among the 5 districts with the highest COVID-19 mortality rates. In addition to districts 25 and 31 in Queens, which also includes Jackson Heights and Elmhurst neighborhoods, as well as Auburn, Far Rockaway, Rosedale, and then in District 12 in the Bronx, which was also on this list, is home to Wakefield, Olinville, Eastchester, and Williamsbridge. Next slide there, and as you can see here, the first key finding that we highlight in our report is that barriers to primary care are consistently associated with worse COVID outcomes. Districts where residents face multiple barriers to care were also disproportionately affected by COVID-19, which is consistent with research across the US that links worse COVID-19 outcomes to a lack of access to care prior to the pandemic. A few examples of this are, we found districts with higher uninsured rates and lower English proficiency. Both of these measures, which are shown in the maps on this slide, had higher COVID-19 case and mortality rates. And then additionally, districts with more primary care providers, or PCPs per person, had lower COVID-19 case rates. And in this section of the report, we highlighted a couple districts where COVID-19 case and mortality rates were among the highest in New York, districts 21 and 25, which on this map here are tucked in the northern part of Queens, where you'll see also have the sort of highest limited English proficiency and highest uninsured rates as well. And these same districts obviously face steeper barriers to care than the city's population overall, and also had some of the worst COVID outcomes. The second key finding that we want to highlight in the report was a notable number of New Yorkers that are delaying and foregoing care entirely due to cost. As many as 13% of New Yorkers in 2018 reported delaying or foregoing care, which is a statistic likely to increase substantially since the pandemic. We found also that higher rates of delayed and foregone care due to cost were associated with fewer PCPs per person and higher rates of preventable emergency department visits. Two of those measures are also shown in the maps on this slide. We also found higher chronic disease rates, which include diabetes, had higher COVID-19 case and mortality rates, and were also associated with delayed and foregone care due to cost. In this section of the report, we highlighted 5 districts in the Bronx, 14, 15, 16, 17, and 18, which include the Morrisania and Cortona neighborhoods. They all had the highest rates of delayed and foregone care due to cost in the city. In the Bronx overall, 1 in every 6 adults, so near to 17%, reported delayed and foregone care at the cost. So despite having more primary care providers than all other boroughs except for Manhattan, ensuring affordable care for these districts and other neighborhoods in the Bronx that are struggling to afford care is essential to ensuring access and closing gaps in health outcomes. And the last key finding that we want to highlight is that Black and Latinx communities in New York City have inequitable access to care, which has persisted for decades despite efforts to close gaps by race and socioeconomic status. And you can check out these maps on this slide here, which show the distribution of Black and Latinx residents across New York City. Districts with a larger proportion of Black residents have fewer PCPs per capita and higher rates of delayed and foregone care at cost. Districts with a larger proportion of Latinx residents had higher COVID-19 case rates, and districts with larger proportions of Black and Latinx residents had higher COVID-19 mortality rates as well. These findings really indicate the dire need for targeted investment in primary healthcare resources to address consistently lower access to care and a disproportionate burden of COVID-19, both cases and deaths in districts with larger Black and Latinx populations, which will very likely contribute to major and long-term negative impacts and deepen existing health inequities. So overall, the report summarizes several findings and key data that all point to the inextricable links between access to care and inequities in New York City. And with these pre-existing disparities having shaped many of the COVID-19 pandemic outcomes in the city. And many are expecting that COVID-19 is going to deepen existing health inequities, both in terms of access to care and also worsening chronic disease and mental health burdens. And so for some New Yorkers, new health issues are emerging at this time, particularly in terms of behavioral health, which are expected to disproportionately impact certain segments of the New York City population. And so through PICSNAP and other investments, where we at PCDC are committed to continually publishing actionable data like these that shed light on communities across the city and broader regions. And so the data and findings reviewed here are all available in the report. You should have a link in your chat box. You can also check out the interactive dashboard. And all of these have helped PCDC identify several key policy recommendations to make more actionable progress toward meaningful change. And so with that, I'm very happy to introduce my colleague, Maura Harris, the Policy and Advocacy Manager, to walk you through some of our policy recommendations.
Great. Thanks, Kirsten. So as I go through these, you'll notice that we've categorized our recommendations into 4 sort of general topic areas that relate to the findings of the report, but that they all sort of overlap in their overall goals, right? So the first recommendation area is access. So commit to long-term investment in community-based healthcare facilities and providers, specifically in areas with a shortage of primary care providers or access points. So there are, of course, a number of data resources that can be used to identify these shortage areas, but PCDC is one of the very few organizations that provides primary care provider availability data at the city council district level. So the dashboard that our analytics unit created that Kirsten and Mary referenced earlier, which is illustrated sort of in action in the animated image on the slide, is interactive and allows you to compare health access measures, including PCP availability, across districts as well as against the city average. So it's a really fun and easy way to interact with this data and understand where the disparities are. And of course, there are many ways to accomplish this goal of investing in community-based facilities and providers, right? It can look like expanding the number and type of available facilities, recruiting providers, and increasing funding for existing facilities through a variety of mechanisms. And advocates also could do additional investigative research in those districts with worse outcomes and lower PCPs per person to ask those PCPs about what their needs and capacities are, which can then inform the subsequent investment. Next slide. So the second recommendation area is of affordability, which of course is a piece of access, right? So strengthen access to low-cost care for uninsured New Yorkers, including by increasing funding for NYC care and expanding it to include FQHCs. So this report, of course, found that New Yorkers have been delaying seeking care due to cost. And we know that this can lead to worse outcomes and amidst a pandemic in particular to increased case numbers and mortality. So in thinking about how to address this, we know that New York has already made a huge investment in access to primary care with the NYC Care program. And we believe that this program could be expanded to more providers to ensure better access to low-income New Yorkers. And tangentially, of course, we know that affordability is not just an uninsured issue, right? Healthcare costs are a burden for many of those with insurance as well. And there are many things we can think about to assist those populations, including providing resources to those who can choose their health plan to help them in their decision-making process, or creating more or promoting existing disease-based programs and programs that can help patients obtain more affordable medications, among many other things. Next slide. So moving on to our third recommendation area, which is equity, which is sort of all encompassing, right? But one finding from this new research is that language barriers are associated with worse outcomes in New York City. So grow and diversify the primary care workforce by promoting the use of interprofessional care teams and recruiting and training providers from within the communities that they serve. So of course, we found that Black and Latinx communities, sort of unsurprisingly, have gaps in access and worse outcomes oftentimes. We know that there are many reasons why it's important to have a healthcare workforce that reflects the community, including in order to strengthen trust and increase utilization of services, especially in light of historical mistrust that is rooted in a long history of systemic racism. And I think policymakers and advocates have a lot of options when it comes to concrete policies that would improve recruitment, training, and retention of providers of all types, right? So in addition to physicians, we're talking nurses, social workers, and in particular, community health workers, which are the types of workers that, when recruited from the neighborhoods that they serve and are really embedded in the community, have been proven to improve trust as well as clinical outcomes. And so there may be opportunities for pilots or other programs to encourage adoption of team-based care models. And I think in this moment where everyone is talking about how to build back better and what we can do differently, it's really the perfect opportunity to think through systematizing the integration of physical health and specifically primary care with behavioral health and social services. So there are certainly pilots in other states and municipalities that we can look to for how to build community-based organization capacity and strengthen referral networks between organizations. Next slide. And finally, our final recommendation area relates to COVID recovery. So equip primary care providers with the vaccine and also the funding necessary to accelerate COVID vaccine distribution and provide culturally competent education about the importance and safety of vaccination, right? So PCDC has found both in this report and in previous research, and Kirsten mentioned this earlier, that districts with fewer PCPs per person had higher COVID case rates. So obviously the first and best way to prevent adverse outcomes from COVID is to vaccinate everyone as soon as they're eligible. And so there are a few things that advocates and lawmakers can consider as they think this through. We should plug into the existing work on expanding access to vaccines for primary care providers with a particular focus on helping these providers educate their patients about vaccine efficacy and availability. And I think it's also important to remember that PCPs are not the only trusted messengers on this issue, right? So it's also essential to equip community-based organizations, faith-based organizations with information so that they can both help people understand why it's important to get vaccinated and then connect them to a provider that can actually get the shot in the arm, which of course reinforces the idea of, really integrating on all of these services between physical health, behavioral health, and social services. And with that, I'm going to just turn it back over to Mary to close us out and take some questions.
Great. Well, thank you both, Maura and Kirsten. I think I can figure out to get my video back on. I think there it is. So thank you all for joining us. That was kind of a short and sweet overview of the report. There are many more data points and insights available in the report, and many more kind of ways that you can play with the data through the interactive dashboard. Links to both were sent earlier through the chat. I'll just pause for a minute or two to see if we get any other questions through here. But really, in summary, we plan to continue this work, both from the policy perspective, advocating for advancements in investment in primary care at local, state, and federal levels. And then we also plan to continue these analytics to draw further insights about primary care access in the intersection with health equity, really through now a lens turning towards some of COVID's resiliency efforts, which I think will be significant and necessary to both prevent sort of deepening of gaps, but also to make meaningful progress towards equity. Let's see. We are happy to hear from all of you on the call today, and to collaborate with you all. I think we all kind of know it takes a village, or in this case, takes a city, to really rally around all of the issues facing New Yorkers with access to care and COVID-19. And we're happy to serve as a resource to anyone interested in either further information on any of the topics that we talked about here, or any of the topics that we reviewed in the report. Let's see, we've got a couple questions. Let's see, so one here, will we look at needs for mental health? That is a great question and incredibly relevant during COVID. We definitely include at PCDC, include behavioral health really in our definition of primary care. The definition of primary care access we looked in the report, you are correct, did not include behavioral health providers, but we actually plan to include that in the coming year's report. So certainly stay tuned for more data on that. We do know through some data that's been put out, not by PCDC, but by others, that the COVID pandemic has certainly had many negative effects on behavioral health outcomes, both exacerbating some existing issues and then creating many other new ones. And as the first, oftentimes the first point of care, primary care certainly needs to be prepared for and equipped to screen for behavioral and mental health conditions, and to be able to sort of facilitate the treatment either in-house or referrals to adequately address that. And then let's see, another question regarding telehealth access and broadband. Another great question. 18 months ago, I probably would have said telehealth access and broadband wasn't particularly relevant when we're looking at data in New York City, but it turns out when you have an entire city that's largely, and in some points in the pandemic, almost exclusively reliant on telehealth access for care, that actually becomes a very relevant issue here. That is also something that's kind of on our docket to continue to explore both at the city level and the rest of state, particularly around broadband access. One of the questions that we're particularly interested in exploring this coming year is really around primary care service utilization during the different phases of the pandemic. So the transition that was swift and in some cases unexpected, in some cases providers got a little bit of a head start to transition to almost exclusively providing services via telehealth, and then the subsequent transition back to in-person services, and now sort of the hybrid model of telehealth services that we're seeing now. I think there's a lot to be learned, just both in terms of what providers did, but then also, are there actually opportunities now that there are more opportunities to provide services via telehealth that could actually address some equity issues, particularly in terms of increasing access for folks who may not have had a provider nearby, may not have had a provider that looked like them nearby, and how telehealth may be kind of a player in some equity issues. Let's see. So I have a couple questions here that are related to partnerships working on primary care access. I think that's a great question. We are certainly kind of open to any and all kind of interest from different parties related to primary care. And again, use a very kind of broad definition of primary care itself, related to behavioral health, women's health services, but also realize that there's a significant and kind of large overlap between primary care and social services and different organizations and people working towards social determinants of health. So whether, whether it's organizations working with housing or homelessness, we think that those folks are certainly an integral part of conversations around primary care access, and have important networks and insights on how to ensure that high quality and culturally competent care can reach all New Yorkers. I think one of the statistics that Kirsten cited earlier in the presentation as well about cost of care, that as many as 13% pre-pandemic, sort of expected to be an increased number now, of New Yorkers are delaying or foregoing care entirely due to cost. And I expect that that's really affecting different segments of the population in New York differently. So I think that all works towards the goal of kind of widening the swath and being very inclusive of all types of partnerships that would interact and intersect with primary care access. So thank you all for these questions. These are really great. And thank you again for joining us today. Just going to pull this up. Both myself and the eval and analytics team, and then Maura in our policy and advocacy unit would certainly welcome any additional conversation, any additional questions. And again, if we can serve as a resource to any of you on the call, to help provide some of the data that we're looking at, or to talk to any other folks that you think might be helpful, we are more than happy to do that. And also always happy to collaborate on additional efforts that are moving the needle on primary care and health equity in New York. So thank you all again for joining us today, and hope you all have a great rest of your afternoon.